Welcome, everybody, to the second in a two-part series featuring Rabbi Samantha Schapera. Rabbi Schapera, welcome back.
Thanks so much for having me again.
My
I'm so glad
pleasure.
to be here.
I'm very excited to have you back as well. So just to jog people's memories, this two-part series is based off of your rabbinic thesis that you completed at Hebrew Union College. You completed for the partial fulfillment of the requirements of rabbinic ordination spring 2019, the title of which is The Future of Jewish Long-Term Care Facilities. Now, to better understand the future, you have to understand the past and the present. So that is precisely what we are speaking about in this session. Last session, we spoke about what makes long-term care facilities Jewish, including a variety of factors, right? Various desiderata that would go into considerations of what would, I guess, help, I don't know, foster a Jewish identity or character to such facilities.
That's right.
This one, we're just going to go in, talk history. So, right. So one thing I will lay this out, which is I know you identified four distinct eras in the history in America, Jewish long-term care facilities. My first question, which is how much previous research out there has there been on this specific topic, the history of Jewish long-term care facilities in America?
So a lot of the research that I did was based on somebody's dissertation. So this person, Edna Friedberg, Edna Friedberg wrote her dissertation. It's called, I'm just going to look at my other screen to get the name, Abandon Us Not in Our Old Age, The Origins of American Jewish Residential Services for the Elderly. And so she actually did all of the research previously, and a lot of her research was, she wasn't looking at sort of secondhand sources where it was, people had written a formal paper or project on it, but she was looking at firsthand sources. So she was looking at, board minutes for, I think she looked at, like 6 different facilities around the country. And so she looked at, like I said, board minutes. She looked at like newspaper articles and histories that were written. So she was doing a lot of the research on her own as well. So I don't know that there's been so much research done, but there's definitely been enough where it's been compiled and somewhat easily accessible.
And she didn't do the entire history. She only did up to a certain time, right?
Yeah, so she stopped at 1935, which I'll talk about a little bit later, but she went up until the Social Security Act was implemented. And that was because that was when we have a huge shift in, one way of taking care of our elderly in like a residential setting and to another.
So let's start at the beginning. Okay. 19th century, right? The first era. When did Jewish long-term care facilities start being created in America in the 19th century?
Yeah, so I think that's really important to point out is that we're talking about America only. So the first one was 1870, and it was opened in New York. It was the home for the aged and infirm. And the and infirm part kind of got added on a little bit later, which I'll also talk a little bit about. But basically, before 1870, before there was this need for, a building or a home for people to live in, the need was really, really, really small for a multitude of reasons. I talked about last week how, the Jewish population was mainly immigrants, and they were quite young when they came over. So there just weren't a ton of Jewish elderly in America to begin with. We get a huge wave of immigrants in 1881, right, when Russia's borders opened. So So right, we're before that, so 1870. And there's a couple other factors. Another one is there was no such thing as an active retirement. So an active retirement is when, like we have it today, where you hit 65 and you can stop working and you can spend the rest of your life kind of doing something active, whether that's traveling or working a part-time job or being with your family. That concept didn't exist at the time. People would literally work until they couldn't work anymore. And the other factor that played into, a lack of need of a home was there was an expectation that children would take care of their parents if they couldn't work and sustain themselves. So all of these things put together make it so that there's just a very small, there's no need at the, before 1870. Around 1870, a little bit before then, right, because we want to look before the home is actually established, you have a very small minority of elderly Jews who don't have any of those things, right? They're not able to work, and they're very poor, and they don't have family to take care of them or who are willing to take care of them. Mm-hmm. And so what happens to them, right? They end up going to a place called a poorhouse or an almshouse. And these places are just really terrible because there's no government regulation at the time. And it's really anybody who doesn't have a place in the society but still needs a place to live this is where they would go. So you have orphans, who are in an orphanage. You have criminals who are living there. You have like alcoholics. And so this place becomes a place of, kind of filth and crime. And it's not safe. It's not sanitary. And this is when you get a group of women, actually. It's women's auxiliary groups who step up and say, this isn't a huge need, but it's still present. And this is something that we can do to help, this vulnerable group in our society. Mm-hmm. So they fundraised, they collected money, they created a house. And at this time, it really was a house. And they went to these poorhouses and they found Jewish poor elderly who had no family, who were living there. And they invited them to live in this house, in the home for the aged.
Where is this? Is this New York?
New York. Mm-hmm.
It is New York. Mm-hmm.
Yes. Yeah. You start getting some other ones, along the East Coast, Pennsylvania. I think there's one that ends up in Chicago. And they kind of pop up here and there. But like I said, the need is really, really small. So, and these homes are like less than 10 beds, right? So it's really small. The other factor that plays into, who's coming to these homes, right? They have to be Jewish, right? As I said, they have to be poor. They have to be without family to take care of them. And they, what was the other thing I was going to say? They have to be healthy. That was the other thing. If somebody is sick, and needs chronic care, they would go to a hospital and stay in the hospital for the duration of their medical needs.
And that could be weeks, months.
It could be years. Yeah, people would stay at the hospital as long as they needed. So it's really important to notice that these early homes for the aged were not medical facilities that we think of today. Because really they were charity organizations, right? So there was no funding or, even management, experience to have, things like therapists on staff or doctors on staff, right?
Yeah.
So what these women would do, and they did it really well, I'll say that, right? They were really, really good at creating these homes for the aged. But it was more like what we would think of as independent living today, right? It was they would provide food and they would provide entertainment and safety, but beyond that, not really much else.
Mm-hmm.
And so that's phase one or stage one of long-term care. Yeah.
So that starts 1870 and
Mm-hmm.
continues roughly until when?
I would say early 19th century. It's different for, every place, but maybe like 1910, 19 teens.
Mm-hmm.
And the reason, oh, go ahead.
Well, I was about to ask what causes it? Is it because of that Eastern European immigration starting in the 1880s? Is that a big prompt for that?
No, not really. Because
Okay.
again, right, people are being taken care of by their families.
Mm-hmm.
So that's still part of the Jewish culture that, and the immigrant culture as well, and partly the American culture is there's the concept of when you get older, you move into a community of people who are the same age as you doesn't really exist.
Mm.
But what does happen is, and the other thing is to remember is there's no active retirement, right? So people come over and they're working,
Mm-hmm.
Even if it's something like peddling wares or, being a seamstress or something, they're not retired. So.
Yeah.
What does end up happening though is that the people who are living in these homes, they get older and they get sicker. And the women who are running these homes, they feel, as they should, right, a responsibility to their, I'm going to use a very outdated term that was appropriate for the time, which is inmates. They felt responsible, as they should, to their inmates. And when they would get older and sicker, they wanted to make sure that they were taken care of, and not send them to the hospital, away from their community.
Mm-hmm.
So the need for medical care within the walls of the homes became greater. And as there's more staff needed, more equipment needed, it's really interesting to watch the change of leadership. Right? We go from a charitable organization that's run by women's auxiliaries to a business that's run by businessmen.
Mm.
So you have this is that shift that we start to see to like I said, to businesses and to facilities and medical facilities at that.
Mm-hmm. And how else? So the main, and that goes until 1935, or does it stop before then? So roughly 1905, 1910 until 1935, it starts to become professionalized.
That's right.
And longer term in-house care.
Exactly.
And a little bit more medical. It becomes a little less independent living, a little bit more medical care provided.
Exactly. Yeah. And definitely not completely, it doesn't, move to a complete medical facility, but they do bring in, like lifts or elevators, or like they make sure that there's, like rails or something in the bathrooms. So there's more things that are put into the facilities that make it more accessible and easier for people who need those things to live.
I'm curious, although you're probably going to answer it soon enough. When does active retirement start happening in America? Or at least popularizing?
Yeah, around 1935.
Okay. It was an unintentional segue.
Yes, there you go. Yeah, so it's really fascinating to look at the history of the Social Security Act, because it's actually, this is kind of a a sidebar, but
what? No. I think this is really important for those less familiar with the 1935 Social Security Act. What was it, and what is its significance for our conversation?
Okay, so the idea is that for your life, you pay a little bit into like a pot. taxes, right? The Social Security tax, it goes into it's the federal government, and then once you hit a certain age, you start to get a little bit of that back.
Mhm.
And before 1935, there was some of this foundation was set up for veterans. So veterans would be able to get money to live off of after they came back from war and weren't able to work.
From the Great War.
Even before then, it was set up with the Civil War as well.
Really?
Yeah.
Oh, wow.
Yeah,
So veterans of the Civil War and the Great World War, or the Great War.
exactly. Yeah, so it's right, we've had it for a really long time, this idea of at some point you're not going to be able to work and you need some help from the government. But it wasn't something that was available to the general public. And in 1935, the act was passed that said, now there's this, right, now you can stop working at a certain age. I believe it was 60 at the time. I can't remember exactly, but it was younger than it is today. And so people were able to stop working and get some money from the money that they put in as they had been working for their lives. And what this meant was there's a larger need for people to live in a community where there's other retired, retirees of their own age, and living together and, like I said, being a community. So the need becomes greater. What's really interesting that happens is the Social Security money would go to the facilities, not to the person, if they were living in a home. But in order to get government money, the facilities had to be non-discriminatory. So no longer could they say, if you're not Jewish, you can't come in. Now it's, anybody of any faith can come in. If you're sick, if you have a chronic illness, you can, you're welcome. There's still some regulations, right? You can't have, and this is actually true today, you kind of impoverished yourself in order to kind of meet the requirements of sort of the financial levels. But we start to get a little more loose in the definition of who's eligible to live in such a home.
Can I go, do you know what was, catalyzed or helped prompt this act? It didn't come out of nowhere. Is it in the wake of the Depression? Did that somehow catalyze the creation of this act? Do you know what the broader societal issues that, the legislation has a context?
Yeah, that's a really good question. So in 1935, we're, kind of in the midst of the Great Depression. So there's a larger economic need for, for everyone, but in our case, right, what we're talking about today is for the elderly as well. I'm going to read a quote really quick that says, let's see, this is from socialsecurity.act.gov, ssa.gov, and it says, the best estimates are that over half of the elderly in America lacked sufficient income to be self-supporting. So there was a lot of struggle, and there needed to be some sort of system in place to take care of our elderly. And that's where, that's kind of the catalyst, as you said, for the Social Security Act.
Yeah. Okay. So that was the background, and then it happens. So clearly the non-discriminatory aspect of the legislation is a big motivator for Jewish homes, really any home, of course, but especially Jewish homes, to not discriminate in their populace, their demographic, right?
Exactly. And you're right that it's not just Jewish homes, because at this time, or before 1935, a lot of the homes that are kind of popping up are religious specific. And we find that today too, right? Hospitals are also kind of connected to different religions.
I would imagine predominantly Catholic, probably to some degree Protestant as well, right?
Mhm. Yeah, exactly. Yeah. Yeah. So they also would have to implement non-discriminatory practices as well.
Okay, cool.
Yeah. Or they could choose not to, but not get,
The money, right? Because they
money.
could tap into donors. Theoretically, they could ask for fundraising, alms for the poor, but here they don't need that recourse if they can get federal monies, right?
Well, we still have a lot of sort of reliance on donors and fundraising. One of a previous project that I worked on was there was a merger. So another side note is that Cedar Village was a merger of two homes in 1997, but they had actually tried to merge in 1960. And in order to do so, it failed, obviously. But what ended up happening is both homes built new facilities. And in order to do that, each one had to raise $1 million in fundraising. So it wasn't just, and they did have, there was government money available for things like ramps or elevators, things to make the building safe for people
More
with mobility
accessible.
issues. Exactly.
Mm-hmm.
But it wasn't enough. So it wasn't like one or the other. It was, it just meant that they could rely less on fundraising and on donors,
Mm-hmm.
but the need certainly didn't go away. What's also interesting is, sorry, I will.
I wanted to pull on that tangent.
Yeah.
I've heard references to
Mhm.
this attempted merger in the 1960s between Glen Manor and the Orthodox home right here in Cincinnati. Not
Mhm.
much did I hear about it. How close were they? Do you know what ultimately made it not happen?
Yeah. So they got very close. They were in talks for a long time. So I did this project as part of a American Jewish History course at HUC. And I looked through all of the sort of board minutes from both the Orthodox home and the Reform home or Glen Manor.
Primary sources.
Primary sources,
Yep.
exactly.
Mm-hmm.
And they got very, very close. What ended up happening was the Orthodox home said, if there's no kosher kitchens, we're not merging. And the Reform home said, if we're not allowed to have, a reform services on campus, we're not merging. And they weren't able to talk through that. And so that's where the mergers failed. It was, and they had, it's fascinating when you look at it because, one of the reasons for merging, and by the way, they had been trying to merge since like the 1890s. So this wasn't a new,
Really?
exactly. Yeah. So the Orthodox
Wow.
home was opened in the 1890s, and immediately the Jewish community was like, why do we need two separate homes for our Jews? Both of them are half filled. And
Really?
yeah.
Really? Oh, wow.
Mhm. And it really came down to, religious and ideological differences that they just could not get over. Eventually, what happened in the late 1990s was the financial cost of having two homes was just too much, and they had to merge for financial reasons.
Mm-hmm. So this third era
Mhm.
from 1935, how long does this third era continue until?
So I would say up and about until today. We're kind of in the midst of transitioning to this fourth stage.
We're in the same era this last 85 years?
Yeah, there's been not a ton of change, and a lot of that comes down to sort of federal funding that comes for research, for standardization, for um, sort of implementation of rules and things. I mean, we're definitely in a much better place than we were in 1935 with government regulations. But
I mean, really? I mean, stuff in the last 4 decades are similar as they were mid 20th century America for these
so,
facilities?
so what it looks like, right? What it looks like when you walk into a facility,
Yeah.
I would imagine is much different. However, as far as financial need, as far as facilities having to, and not the facilities, but the management team having to respond to sort of outside pressures, that hasn't really changed so much. You know, things have remained pretty, on a business level and on a sort of management level. I would say things have remained pretty steady up until probably the last, I don't know, 15, 20 years. And we're slowly transitioning to this fourth stage. There have been some things that have been implemented like here and there, but I would say we're kind of in flux to changing what a nursing home means, or long-term care means.
So from what you were saying about the financial pressures, outside pressures, I'm curious, and touching back on our first session of the Jewish component, Jewish aspects, I imagine those changed as each of the different eras changed as well, right? To some degree, they would have a different look from 1870 to 1910, 1910, 1935, 1935 to the present. The Jewish aspects might have changed to some degree, like different, right?
Yes and no. I would say the first two stages, the Jewish aspect didn't really change so much, because there were no, unless there was a very rare circumstance, there were no non-Jews living in the facilities. They had, not only was that kind of the management prerogative, but that was the norm across America, right? The Catholic facilities would would take care of the Catholic elderly, and the Lutherans would take care of the Lutheran elderly, and the Jewish would take care of the Jewish elderly. In 1935, we start to see a change because there's more and more non-Jewish residents who are coming in. However, that doesn't change very quickly, right? It's still, there's the Jewish home and there's the Catholic home, and people kind of go to the place that they identify with the most, right? We talked about last time about, when I was asking chaplains and CEOs and administrators what makes a Jewish home Jewish, and their answer was, it's a place where Jews don't have to explain themselves. And I think that was a huge attraction for Jews to go to a Jewish home. We start to see, as and this is definitely a national trend, as people become less connected to their religion, and become more secular, is that going to a Jewish home, because that's where I'm Jewish, or that's where I don't have to explain myself, is less of a push factor. People are less drawn, Jews are less drawn to Jewish facilities because they're Jewish. It might be because, well, I'll say it this way, the two factors that really tend to draw people to a home are location and reputation, much more than sort of religious identity. And part of that is because, the people who, especially if somebody is going into skilled care, the people who are making that decision are their children. And the children, are even less connected to their religious identity than their parents. I mentioned in my thesis that, if I'm working and it's the end of the day and I need to go visit my loved one who's living in a long-term care facility, I would much rather drive 5 minutes than 30 minutes, especially if my, and not mine, but especially if my connection to religion is not that an important of a factor. So, and then reputation as well, obviously plays a really important part. Um, yeah.
So I have a couple other questions
Go ahead.
as far as potential changes go. One question
Mhm.
is, I imagine to some degree is both the constituency, like the demographics of the residents, as well as, and I think to some degree children do factor in, I would imagine. Right now, we have currently primarily in our facilities are members of the silent generation, and
Mhm.
we are now starting to begin to have some baby boomers in
Mhm.
here. We uh, I wonder, what about before the silent generation? Were there, whether it's those folks from the interbellum generation or the greatest generation prior to the silent generation, how much were there differences? I'm thinking specifically insofar as Jewish identity is concerned. Maybe the way that Jewish identity gets differently expressed or identified with. I, I'm the baby boomers for sure are different than
Mhm.
the preceding generations. I don't know how much or how similar silent generation is, or from the greatest generation, so-called greatest generation that preceded them. Do you know if there were many changes with Jewish identity, Jewish practice from one generation to the next, the last few generations?
That I'm not so sure about. Yeah.
Hmm.
My research didn't really go into kind of those middle years of say like 19, you know, 60s and 70s.
Okay.
So yeah, I don't know that I have an answer for that question.
Okay. And then a separate question, which I know has been going on certainly for more than a decade, certainly in the last decade, probably more than the last decade, of more in, like, basically in-home help.
Mm. Mhm.
Um, I actually, this is super random, but I have a little prop here. I'm very, very excited about this. There was last weekend or week and a half ago in the New York Times, page SR4 in the Sunday, January 3rd, 2021 New York Times. Over the past few decades, the popularity of aging in place combined with new medical technologies and longer lifespans has changed the nature of care for seniors and people with disabilities. Residents of the nation's 15,400 CMS certified nursing homes are much older, sicker, and poorer than they used to be. So that's New York Times.
Mhm.
So I imagine the home health movement over the last, what it was, last couple of decades. I imagine to
Mhm.
some degree that's also affected not just the nature of the care at such facilities, but also who is here and how
Mhm.
much involvement there is with the Jewish life aspects. I think you mentioned in our previous video that, but prior to necessarily in building chaplains, there would be a lot more residents involved with helping create Jewish life, Jewish practice, Jewish
Mhm.
services, and with at least according to this New York Times piece, it would seem that there's a that would affect the activities, right, of
Mhm.
those in such facilities.
I imagine so.
Would certainly. It also, to me, it sounds like it also sounds to me like it's not the same destination as it once was for Jewish seniors,
Mhm.
seniors of all stripes in America, but especially even Jewish seniors. It's no longer the place you're going to go and have basically adult
Mhm.
retired dorm life with necessarily as much. But if you need the care, you can have it at home. The aging in place movement, right?
Mhm. Yeah, exactly. And so talking about, some of the, we move from stage to stage because there's, outside factors that are, um, forcing facilities to kind of re-examine themselves or, um, respond to things that are coming down from the government or something. Um, and in this case, it partly has to do with insurance, right? It's much, much cheaper for people to stay at home. And insurance and I'm thinking more of like, short-term skilled care, right? Rehab,
Mm.
right? Before, right, people would come to a facility like Cedar Village, right, for
Mm-hmm.
rehab after surgery, now they tend to go home after surgery and get in-home care. And we find that same kind of idea with long-term care as well.
And that was probably the case, you're saying, even prior to the present global pandemic, right?
Oh yeah, for sure,
Yeah.
for sure.
Yeah.
Yeah. So all of my research was done pre-pandemic,
Right. So all the
um,
more so nowadays, right? Meaning,
well,
I would imagine a lot of people who even just need not even the long-term care, who just need the rehab, if they
mhm,
have the choice between going to a senior living facility where COVID can easily be present
yeah.
versus getting in-home help, right? If the insurance is,
Yeah, that I don't know so much. I would assume so. That makes sense. I'm also thinking that I know a lot of services stopped for a while because, people didn't want to go into other people's homes and spread something perhaps from one home to another. Um, I don't I don't know what's happening at this present moment, but I do know that that idea of it's cheaper to stay at home longer, kind of a callback to, the mid to late 1800s when families were taking care of their loved ones. We find that again is um, our seniors are either living in their own homes as long as possible or they're moving in with their children because it's cheaper. There's less sort of, applying for Medicaid can be a really daunting and long process. And if you don't have to go through it, sometimes that's, an easier choice. Um, it's like everyone else is doing it, right? So there's one of the reasons that people would move into, and even today perhaps, that people would move into some place like an assisted living is because that's where their friends went, right? The
Mhm.
community, like you said, the community would kind of move there as part of Jewish life, and
Mhm.
that's not really the case anymore as
Right.
much as
Right,
much.
right. Especially what I just mentioned from that article about more aging in place aspects.
Mhm.
It to some degree decentralizes Jewish senior living facilities as
Mhm.
an ultimate destination
Mhm.
for the more senior in the Jewish community, as
Yeah.
opposed to saying this is going to be my like a senior dorm lifestyle, uh, and then this really decentralizes it as less of a destination.
Hmm. Absolutely. Yeah, absolutely. And that's one of the many reasons that I argue that we're kind of transitioning into a fourth stage,
All right.
not taking COVID into account, but
Right.
um,
So this was, even you wrote this before, your research and your ideas were formed prior to the current global pandemic.
yeah,
All right.
yeah,
Disclaimer, disclaimer, disclaimer. This is pre-COVID.
yes, yeah,
Okay.
yeah. Well, I mean, like I said, it's cheaper, so it's there's a lot more pressure on the caretakers, absolutely, um, but there's more pressures that come onto our senior citizens that would encourage them to age in place, right? Um, in addition to all of those pressures, right? It's cheaper to live at home. There's not as much, your friends or your community is moving into these places. Um, the facilities themselves are, dealing with some pressures as well, right? Medicaid is just as difficult to work with for facilities as it is for individuals. So
Mm.
um, healthcare facilities work on a reimbursement model. So it's hard to describe, but basically Medicaid will say, this is how much that we'll reimburse you for each patient or each resident, depending on what unit we're talking about. And it's not always enough to cover the cost of somebody living there for an entire day. So you do it on a day-by-day basis. So facilities are really struggling financially, and so they're having to kind of um, take the time and decide who are we serving, how do we bring in more revenue so that we can continue to serve the people that we need to serve.
Hmm.
um, and they're doing this, and this is kind of my my final argument for my thesis is, what is the future of Jewish long-term care? And the answer is diversification, which is a very broad word, right? It's not very specific, and that's intentional, right? There's not one way that Jewish homes for the, I'm not going to say elderly because it's not really just for the elderly anymore, but Jewish homes, I'll just say that, Jewish homes are responding to some financial issues.
Why not elderly?
Well, so I'll tell you why. So some places have decided that the way that they're going to survive is through diversification of revenue. That means that they're going to offer services that will bring in revenue from a lot of different pockets. So they're not reliant on donors only, they're not reliant on Medicaid only, or even a combination of the two, but there's a lot of different places where money's coming in, and if one of them fails, they're still going to be able to survive. Mm-hmm. We found this in California, actually. I was talking to a chaplain at one of the homes there, and California, I'm not sure when, in all of my research, I couldn't find the year that this happened, but they removed themselves from the federal Medicaid system. And suddenly, all of the facilities, I mean, everything, right? Hospitals, homes, like long-term care facilities, anything that relied on Medicaid and Medicare, I think it's actually just Medicaid, they were suddenly put in this position where they had to find funding because their primary source of revenue was just taken away from them. So California actually created their own Medicaid program. They realized that it wasn't sustainable, and they created something called Medi-Cal, which is basically a combination of Medicaid and Medicare. But it kind of woke a lot of people up, and I think this is something that a lot of facilities, and in this case, when I say facilities, I don't just mean like long-term care facilities, but are coming to the realization of is we can't just rely on one or two sources of income. So when they're diversifying their services, they're reaching out to people of all ages. So in one home that I looked at, they created basically a community center. Like they had this huge construction project, and they created like restaurants, and they had like a venue for concerts during the summer, and they had some rooms for like business meetings, and then they also had people living there, like residents who were living there full time. And so they were bringing in revenue from people of all ages. There was another facility that, kind of had its main building where all of the residents lived, but then it opened up kind of satellite locations around the city, specifically in the Jewish areas, that had things like a brain and spine center, or primary care doctors, or different kinds of specialty satellite locations, so that they were serving people of all ages, but it was, multiple sources of revenue coming in.
Although that primarily works because of the Medi-Cal system, would that work necessarily in the rest of the country with Medicare, Medicaid?
So that satellite location was not in California.
Oh wow.
Mm-hmm. Yeah. So we find people, and we even find that in sort of our typical, what we would think of as nursing home today, right? You have rehab facilities, you have, some places have like their own pharmacies, if they have outpatient therapy, if they have, some places will have what's called respite care, which is where, if somebody's aging in place and they're living with their caretaker, but their caretaker, maybe their child or their friend or whoever, needs to take a vacation or go on a business trip. So sorry. They can basically live for a very short period in a long-term care home. And so that's another source of revenue. Some places are implementing like what's called adult daycare, which is exactly what it sounds like, right? If somebody's living at home with their child or relative, but they need 24-hour care, instead of bringing in an aide, which can be very, very expensive, they will instead, and isolating as well, they can go to
drop them off for the day.
Yeah, in a community of people who are, the same age as them. So, and it's much less expensive than, living in a home full time. So, yeah, so even without these sort of satellite locations or the restaurants, you still have that diversification of revenue. You also have the alternative, which is really fascinating. I was thinking about it today of, how would I define it as diversification? And I'll tell you what the answer is. So you have some places that are actually downsizing. So they're reducing the number of people who can come and live in their building. And the one place that I interviewed that was talking about this was, we are, this is what the chaplain there said, we're bigger than the Jewish community needs us to be. So that means, if we want to kind of remain as, our founders desired us to be, we need to fit what the Jewish community needs. So we're going to downsize, reduce the number of people who can live here, but also have the larger majority of our residents be independent living. Independent living, if you're living in an independent living unit, you can't use Medicaid to pay. You either have to pay out of your pocket, or you have to you have like long-term care insurance. So that means that the diversification isn't coming through, multiple different services, but through the individuals. So if one person leaves for some reason, you're not losing, a huge sort of percentage of your revenue. So yeah, so we have diversification is the future.
Interesting. Wow. And who knows how much COVID's going to affect everything. Although I wonder if COVID in the post-COVID world, whatever that may even look like, if that could may even move more towards your model of the future. It really, things could open up a lot more. Who knows?
It could be, yeah. I mean, partly, I don't know what's going on now because I'm not really researching it. I'm not in there, right? But also, like, we're all in the midst of it. And
right, we're still in the thick of it. There's still, this month, there's still new daily death records being set every day. So we're not out of it yet. And so how this will affect, obviously, everything, but specifically this industry and broadly, and then in the Jewish senior living facilities more specifically, it'll be interesting to see A, how it shakes out, and B, whatever and whenever that post-COVID era comes.
Yeah.
Who knows what it'll look like.
And it's interesting too, just kind of thinking about it is, I talked about how the stages change from one to another when the homes have to respond to outside pressures, whether that's financial or governmental or whatever.
Yeah.
But before they respond, there must be that moment of like survival, right? How do we remain afloat? And then when they realize that either they can't remain afloat doing the things the way that they've always been done, or it's not going to be as successful for us or our residents, then we have to change. I think with COVID, we're kind of in that survival mode right now, right?
Yeah.
We're just, we have to make sure that we get through this era, and then we can see what forces are kind of on us to change if we even need to.
Right. I imagine there's very few institutions in America, probably the world, but very few institutions in America that won't change in some fashion due to the pandemic. Obviously, it's adversely affected senior living facilities, as we first saw in the state of Washington, and then after that, it's and even here in the state of Ohio, it's adversely affected this population versus any other segment of the population. So it'll be an interesting fallout. Of course, I'm also really specifically interested, and this is less germane to our conversation, I'm very deeply interested in how it affects the rabbinate, but that is probably a conversation for a totally separate time. But how it affects the rabbinate will be ultimately shaking out really interestingly.
For sure, definitely.
Yeah. Rabbi Schapera, thank you so much for this conversation, bringing your wisdom, your research, and your knowledge, of course, your time. So thank you so much.
Thank you. Thank you for having me. I'm glad to share all this research that I did with everyone.
Yep. More than just on your rabbinic thesis. A lot more people can view this.
Yes.
Awesome.
Thank you.